Okay, so I think that Dr. De Jong and Dr. Stephen Jeffrey might be a little, doctors. Unfortunately, the schedules don't always like to stick to the diary. So perhaps we should get started. What I'm going to do is I'd just like to, again, thank Dr. Jason Bennett for joining us and presenting on today's topic, which is HPV and beyond vaccination. And we have Lorraine Govender with us, who is joining us from the Cancer Association. Obviously, we all know that HPV is one of the leading causes of cervical cancer. So just to start us off, I'm going to share a video which has some really great information for us. So if you guys just give me a sec. Yeah. I'm going to share that screen.
HPV is a virus that affects girls and boys. In South Africa, approximately 5,700 women develop cancer of the cervix. Did you know that 3,000 women die from cervical cancer every year? Cervical cancer occurs in the lower part of the uterus, womb, that connects to the vagina, and is caused by human papillomavirus, commonly known as HPV. HPV is a sexually transmitted infection that can spread from one person to the other, between men and women, causing various other cancers, but the most common form is cervical cancer. Because people can be infected with HPV and not show any symptoms for a long time, you can protect yourself from HPV by getting vaccinated. Being vaccinated is easy, safe, effective, and provides protection, especially among sexually naive girls. Being vaccinated protects you against a range of cancers and diseases by more than 150 types of HPV, including genital warts. The vaccine is available at no cost at public primary schools for girls aged 9 to 12. Parents and caregivers must sign a consent form to allow the school health nurses to vaccinate. For full protection, you need 2 doses, 6 months apart. You can also get the vaccine at your local pharmacy or doctor, privately. Girls from 9 to 26 years are able to have the HPV vaccine. Our bodies matter, and we need to take care of them. Lower your cervical cancer risk by getting the HPV vaccine. Take care of your own health, and the health of others.
Thanks so much. There we have them. Great
There
stuff.
we certainly do. Good evening, ladies and gentlemen, and Karen. My name is Peter de Jong, and of course we have the ubiquitous Professor Steve Jeffrey with us this evening, who's the director, is the director of the Pelvic Floor Foundation of South Africa. And it's wonderful also to have our presenter, Dr. Jason Bennett, who's going to be presenting on HPV vaccination. And we also, for the first time, are in association with the Cancer Association of South Africa. It shows you how important the topic is, Dr. Jeffrey, because the Cancer Association of South Africa and the Pelvic Floor Foundation of South Africa, with the sponsors, are proud to present Dr. Jason Bennett this afternoon. We've had a few talks on vaccination it's a vaccination month, as you know, Steve. The WHO vaccination month is drawing to an end. And I'm also very excited not only to hear about the HPV vaccination this afternoon, but I don't know if Jason's aware of the RSV vaccination that's coming up as well. Jason, are you with us?
Hi, thanks. I am. Thanks for having me.
Yes, I also want to take the opportunity. Thanks, Jason, for agreeing to give this talk. Jason's actually a subspecialty trainee in gynecology oncology at Tygerberg Hospital, and you're also in private practice. So great combination, and we are very happy to have you, Jason. Jason's also a keen surgeon, but yeah, absolutely glad that you're able to enlighten us on this whole issue of vaccination. We do have a lot of vaccination talks on these webinars, Pete.
We do, because it's so important. I mean, have you ever heard of RSV vaccination?
I've heard of RSV, but not the actual vaccination.
No, it's something that's
a new thing.
It's a wonderful thing, because vaccination not only protects the actual vaccinator, but also the baby. So it's something to consider as well, Steve. It's like a double protection.
Excellent. Yeah. Well, I think there's time is running, so maybe we can get Jason to start, and we can continue to talk about vaccination a little bit later.
Why not?
Thanks, Jason. You can share your slides. Thanks so much.
Okay, great. So thanks for having me. So as I said, I work in private, and I'm also part-time at Tygerberg. So I think I have a good mix of what's available in private healthcare and what's available in state. And I think for my colleagues in state, I think a lot of the time they don't see a lot of vaccine or get a lot of vaccine questions. I think in private it's becoming, thank goodness, more and more popular, and it's such an important topic. And the HPV vaccine can really make a massive difference in society and decrease the burden of cervical cancer, but also other types of cancers, which we will get to. So I just, while I was going through a few things, I just thought this was a really nice infographic from the Royal College Instagram. And it just shows kind of the big important stages in a woman's life. And they've highlighted here, very importantly, the HPV vaccine. And I just think that was quite a nice representation, that it should be a very important part of any woman's milestones in their reproductive health. So just a little bit of background. In 2018, there was a call to action by the World Health Organization and Director General for the elimination of cervical cancer. And in 2020, they launched the global strategy with 3 targets. And I'm sure you guys have heard this before, but it's 90, 70, 90. And the aim is to vaccinate 90% of eligible girls against HPV, to screen 70% of eligible women at least twice in their lifetime, and then to effectively treat 90% of those women with a positive screening test. If you guys are interested, the World Health Organization has a new kind of screening book, which I've highlighted here. It's very easy to understand, and it includes every sort of HPV and cervical screening available. It is definitely worth a read. So just as an introduction, or the basics, HPV, it is a pathogen that is sexually transmitted. Persistent infection with these high-risk genotypes causes nearly all types of cervical cancers. So there is less than 1% that is not caused by HPV. And hence there is a debate about the death of the pap smear. Or is the pap smear dead? Julie Whittaker spoke about it the other day. So HPV 16 and 18 cause 70% of cervical cancers. Types 31, 33, 45, 52, and 58 cause an additional 20% of cervical cancers. What's important is also just to look at 90%, or type 16 and 18 cause 90% of anal cancers, and then a high proportion of oropharyngeal, vulvar, vaginal, and penile cancers. And I think, being at Tygerberg, I think we realized the burden just of vulvar cancer is quite immense. I think more than anyone really kind of understands. So I think by using the vaccine can really make a great change. So the HPV vaccine was developed to protect against the acquisition of HPV and HPV-related diseases. In this lecture now, I'm going to talk about the basics of the vaccine. And later on, I'm just going to move a little bit into therapeutic vaccines and what we may see in the future, what we may hopefully see in the future. So just to highlight, I'm sure everyone knows about the 3 vaccines that are available in South Africa. So Cervarix is made in China, and it's approved for use in resource-limited settings. It costs 109 Rand. They're all prophylactic vaccines. So they prevent initial HPV infection. We have Gardasil, or Gardasil 4, or quadrivalent, protects against 16 and 18. And here we see the 6 and 11 being introduced. Anogenital warts can be quite difficult to treat, and they can cause a lot of morbidity. And it is important to vaccinate for them. And now we all have Gardasil 9, which we'll chat about a bit later. So the difference between Gardasil 9 and Gardasil is that it includes types 31, 33, 45, 52, and 58, and it is available in the private healthcare sector. So what is the rationale for the HPV vaccine? Well, HPV is common, and the vaccine prevents infection and cervical changes. The lifetime risk for someone acquiring HPV is 50% for sexually active males and females. Some studies I read is even up to 70%. What is important now is that 5 years following your sexual debut is the highest risk for acquisition. The median age of sexual debut, this is in US and UK studies, is 15 to 16. From what I understand, it is much lower in South Africa, 12 to 13. Just some modeling studies that they did in the USA, and they said that if they vaccinate all 12-year-old girls who are vaccinated, hypothetically, they could prevent 200,000 HPV infections, prevent 100,000 abnormal pap smears, and prevent 3,300 cases of cervical cancer. So that is quite astounding, even though it was a modeling study. In areas that there's high vaccine use, they've noticed that there is herd immunity amongst males. And then just going back to the goal of elimination of HPVs, the WHO World Health Organization aims to eliminate HPV in 100 years' time. Remember, elimination is different to eradication. So elimination is having less than 4 cases in 100,000. Just so that you are reminded from your days of writing primaries, what the HPV looks like and how the vaccine is created and made. We can see that there is a viral capsid containing L1 and L2 proteins, and then inside is the genome with all the coding information for E2, E6, and E7. How the vaccine is made, so you can see on the, I can point here, I don't know if you can see my pointer, but on the right side, we have the actual HPV virus, the capsid and the genome. And then we have inside, we have the coding information. The coding information for the L1 gene is inserted into a cell, and through this process called fermentation, it's quite a complicated process. The new capsid proteins are coded, translated, and they are made, and they're inserted into this empty viral capsid. So the HPV vaccine does not contain any DNA, and it is therefore non-infectious. So just the immunogenicity of the HPV vaccines, and we can all see that there's excellent antibody responses with all the vaccines. So it's 93 to 100% seroconversion in females, and then 99 to 100% seroconversion in males. If I just highlight a little study here that showed titers at 7 months and then titers at 8 months. And we can see the top one is showing type, so you can see 16, and the bottom one is the 18 months, 16, all getting very high titer responses. The duration, so we'll come back to that a bit later, but it seems like they're excellent. The titers stay for a long amount of time, at least 10 years. No one knows exactly. But it's important to start noting now that there's no defined minimum threshold for titer for protection. So no one really knows. Just going over here with regards to immunogenicity, and I think this is important because we can see how important it is to vaccinate young girls before they become sexually active. So GMTs are geometric mean titers. So it measures kind of the antibody that you're creating with your vaccine. And we can see that it is much higher in a younger population compared to an older population. And GMTs in a 9 to 15-year-old were significantly higher. Some studies showed up to 2 times higher than those in the population group between the ages of 16 and 26 for all genotypes. This little diagram on the side, I mean, it isn't the greatest diagram because they've pooled results, but we can see the green, we are comparing the green and the blue, and we can see there are much higher titers in the green, which is the 10 to 14-year age group. I think they could have done that a little bit better. Immunogenicity comparing to the different vaccines, or quadrivalent versus bivalent. And this I actually found quite interesting when I first started looking at the vaccine early on in the year. So when they did a head-to-head comparison of the quadrivalent and the bivalent vaccine, they used 18 to 45-year-olds. The bivalent actually produced GMTs that are significantly higher, 2 to 4 times higher compared to the quadrivalent. The non-valent and the bivalent had similar results. But still, no one really knows if higher titers has any impact on the degree or duration of protection. So efficacy, the HPV vaccine is extremely effective in preventing cervical disease, including SIN2 and worse lesions, SIN2 and SIN3, adenocarcinoma in situ, also effective in decreasing cervical cancer and decreasing vein and VIN lesions, which are also problematic and are more common than we actually think. The efficacy is greatest in those who do not have prior HPV infection. I think that video also just showed it, a very nice video that was shown beforehand to show that we get better responses in someone who's HPV naive, meaning they've never been exposed. Furthermore, highlighting the necessity to vaccinate girls when they are young, when they have not been exposed to HPV. So just looking at efficacy just with the quadrivalent vaccine, so they looked at after 3 years efficacy for preventing SIN2, it was 97 to 100% for HPV naive patients. That is astounding. When they looked at the overall population, it was 44%. And then VIN2 and VIN3 was 100% in HPV naive patients. The non-valent vaccine of note is the effect of the overall population in reducing high-grade cervical and vulval cancers. So as I said, the overall population rates of high-grade cervical, vaginal, and vulvar disease were the same as those who received the quadrivalent vaccine. We can see here, which is what is available in state, is the bivalent vaccine. So prevention for SIN2 lesions at a 4-year follow-up was 99% for HPV naive population and 61% for the overall population. I'm going to come back to what is available in state and how the vaccine process works. So the age related. So it is safe and effective in preventing infections in older females. I think this is a question that we get a lot in private because I was quite, even though we look at the, we see all these patients and we have the vaccine available to us and we ask our patients, I ask every single patient if they've had the vaccine, a lot of them have kind of never heard about it or they have no idea whether or not they have had it before. And so we have a lot of older females asking about the vaccine. And I think it's important to kind of know and be able to make a judgment about whether or not to give it. So it's safe and effective in preventing infection in older females, but the overall benefit is less compared to younger females. So we can see that HPV naive patients who've never had HPV was 91%, but then when they looked at the overall group, so that's including the older women who may not be HPV naive, it was 22% reduction. Efficacy, so well, talking about duration of protection, so there is excellent duration of protection for the time periods that they were studied. They realized that antibodies do persist for at least 10 years post-vaccination. And as I said, the level of antibody that you need is kind of unknown at the moment, but there are studies working on it. So anogenital warts, I think this is important just to cover it, because we need to think in the state sector, they do get Cervarix, which is great, but Cervarix doesn't cover 6 and 11. So I think it is kind of important to think that the quadrivalent vaccine does include a whole lot of cover for warts, which can be quite difficult and problematic to treat. So there's a concept of cross-reactivity that I found quite interesting. And they did a study in Scotland, and it looked at HPV prevalence following the National Bivalent Vaccine Program. It was a 7-year cross-sectional study. And they did find that HPV reduced the odds of getting the HPV bivalent vaccine, reduced the odds of getting HPV 16 and 18, but it also reduced the odds of getting type 31, 33, and 45, which means that patients receiving the bivalent vaccine are definitely getting some cover for other HPV types due to cross-reactivity. Safety.
Jason, sorry, so can I just ask you something about
sure.
HPV 31? Because I saw Nicole Morse, the pathologist from Lancet, yesterday, and she said they're getting a lot of HPV 31s. Does that concern you at all with the bivalent? It doesn't seem to be making a clinical difference as much as one would think, but what do you think? We're heading towards going more for the non-valent now, or what is your thoughts on that?
Well, I think in private, I mean, we should be kind of pushing the 9-valent, but I have noticed that, and I saw Nicole did say that they're noticing more of the type 31s. I think everyone should be at least going for quadrivalent or for the 9-valent with some cross-reactivity. But I think if you are getting cover in type 31 with the Cervarix, I mean, that should be covered. But I'll just chat to Nicole about that, about cover and type 31, and if they feel that this is kind of appropriate with Cervarix, if there's adequate cover for 31. That's one thing I just don't know, if you're getting adequate cover for type 31 with the bivalent.
You know, if they do screen routinely for 31 now as well.
Yeah, there is a group of 31. Yeah.
So yeah, she says there's 6.
There is. Yeah, let me just check. So if you use Lancet, the extended genotyping, I think they are including 31.
They are. And we'd like just at this point thank Lancet for sponsorship.
Yes, thank Lancet for sponsorship. And I think Lancet is really great with HPV screening, and the extended genotype screening is amazing, and they're always open to answer questions. So I think it can sometimes be a bit of a minefield. I'm sure I keep this like right next to me all day. I'm sure you guys all have it as well. And yeah, as I can see, type 31 does change things quite significantly, in that if someone screens positive for type 31, you're going to go straight for colposcopy.
Okay, great, thank you.
So safety. So safety is something that, so safety, I was chatting to someone, I was counseling someone with a stage 3B a few weeks ago, and she had fulfilled the normal government screening. I think she'd had one pap smear in her life. I think she was in her 40s. And I've asked everyone routinely if they have had an HPV vaccine. And obviously I said, have you had one? And then I said, has your daughter had one? And she was quite surprised. And the first thing she said was, no, definitely not. I would never let my daughter have the HPV vaccine. And this is quite strange coming from someone who had just spent ages telling her cancer is most caused by HPV, and there's a vaccine. And she said, no, we are just very scared of it. There's too much information about it, and we would never allow our children to be vaccinated. I just thought there really needs to be some sort of more education about the safety of the HPV vaccine. So I did more of a deep dive on it. And basically what I found is almost every single myth that I've been told has been dispelled. So there is lots of documented safety in very large clinical trials. They all use virus-like particles that mimic the viral capsid. There's no genetic material inside. The biggest side effect that I could find is injection site reactions, and the injection site reactions increase as the the valency increases. So for example, there were mild reactions with Cervarix, you get slightly more with Gardasil, and then slightly more with Gardasil 9. And it's just a mild reaction on the skin, which hasn't caused any complications. Syncope is a side effect that happens with almost all vaccines, and almost all vaccines have got a warning saying that you should be monitored for 15 minutes after receiving a vaccine. And I think HPV vaccine, everyone receives the same monitoring, similar to when we all got COVID vaccines. There are anecdotal reports of the HPV vaccine and demyelinating disorders. There was a study of 4 million that disproved this. I had someone the other day who I started mentioning the vaccine, and I think was probably the wrong person to start talking to vaccines about. But apparently she told me there's a whole ward dedicated at Cape Gate to patients who've now had the HPV vaccine and now they are paralyzed. I checked, there's absolutely no ward, and there's all anecdotal kind of responses. Venous thromboembolism, all the findings were non-significant increase in venous thromboembolisms. And when they went back and re-looked at all of the ones that did have venous thromboembolisms, they had multiple other risk factors associated with it. There's been actually a study that the HPV vaccine does not decrease sexual inhibition. So some people felt that having the vaccine opened a doorway for their daughters to be sexually promiscuous, but that has been absolutely disproved.
Jason, can I just come in over here at the end of this slide? You know, we had a talk last week about vaccination, and it seems that there's always a group of denialists that you can tell them till you're blue in the face. They will never, ever accept the scientific evidence and the data that you present to say that it's safe, because they will always have some wrinkle just to, like this award at Cape Gate saying there's a ward full of people that have had bad reactions. You will never get away from that. And it's just like telling people, diabetics, not to eat sugar. There are always some that will be vaccination denialists. And I guess there's nothing you can do. That's just the...
It's very frustrating. And I've always actually wondered what to actually do about it. And you can always, I don't know, I'd kind of just tell them the facts, but then they normally start shaking their heads. And then sometimes just, I don't know, have to do some deep breathing and then kind of let them go and do their, and let them make their own minds up. I think from our side, you give them the education that they need and you give them all the facts, but I realize they will refuse. And I think no matter what you say to them, they won't change their mind.
Jason, here's one question you have from your friend in Egypt.
Habib Habib.
Yeah.
No, he's always sends it as anonymous. And Habib, anonymous, I mean, not Habib, says from Kenya. What does he say, Steve?
If someone has already received the bivalent vaccine, would it be recommended that they get the nanovalent vaccine, or would they be covered due to the cross-reactivity?
So that's a very good question. I have a slide on it, but the guidelines actually say no, it's not necessary. But you also just need to consider that the quadrivalent vaccine is also covering for 6 and 11, so anogenital warts, which can be quite problematic. So that may be something, but the guidelines say you don't necessarily have to have the quadrivalent or the 9-valent vaccine.
Okay, and then one last comment from Lorraine Govender. She totally agrees with you. Ignorance on efficacy is a huge challenge despite the awareness. And then there's obviously some confusion between the HPV and the COVID vaccine. Maybe just the COVID vaccine bringing in a whole new anti-vaccine sentiment and giving airtime to that. So but it's an interesting discussion. And
but Steve, that's what we had at the end of last week's discussion. There was a person that came on and said, despite all the stuff we'd presented, they said, no, this is nonsense stuff and it's a dangerous game we're playing of this vaccination. So you can take a horse to water, Jason, but you can't make him drink it.
I totally agree. I agree. And it creates a lot of kind of frustration. And I agree. It can be very, very difficult. I agree. Like, I think the COVID vaccine, as you mentioned the word vaccine, I think something sometimes clicks in someone's mind that they get very defensive. So just going back to administration. So I think this is important. So for gynaes, we don't see any kids. Like I don't see any children. So we kind of miss this. But I think it's important for us to have a basic understanding of how the vaccine schedule works. To be honest, I asked a lot of my pediatric friends, and I've asked a lot of GPs about HPV vaccines. And to be honest, a lot of them don't really know. And I think they kind of rely on us to kind of maybe guide them and kind of encourage them to do the vaccine. Some pediatricians do know a lot, but a lot of them don't. And I think pediatricians and GPs is where the HPV vaccine can really be enforced and pushed through. So it's divided into 3 groups. So, well, number one, the guidelines that I'm going to talk about now, they're based on the Advisory Committee on Immunization Practices. So it's international guidelines. It's not what's available in the state. They're similar to those for CDC, American Academy of Pediatrics, ACOG, and the American Cancer Society. I will come back to what's practiced in South Africa. So what they say is routine vaccination should be to everyone between the ages of 11 and 12. It can be started at the age of 9 years of age. Then they have this thing called a catch-up vaccination. So anyone who missed those vaccinations should definitely receive a vaccination if they weren't adequately vaccinated between the ages of 13 and 26. Then there's this another group of shared clinical decision-making, which we see a lot in private about patients who never received the vaccine. They didn't have the opportunity, may not have been available, and now they're asking about the vaccine and say they are 35 years of age. And I think it is a kind of, as I said, shared clinical decision-making. As I said, it's not as effective as being vaccinated when you were younger, but I think there is still a place for it. And I think it still should definitely be examined. What's important is that the restrictions or age restrictions. So I've written it on the bottom right. Gardasil 4 is specifically for males aged between 9 and 26, and for females between the ages of 9 and 45. So from our side, there was an age restriction. Gardasil 9, anyone can receive it, even men above the age of 26, obviously younger kids as well, children. And women can, above the age of 45, can now also receive Gardasil 9. If you go to the Gardasil website and the US site, they're going to say restriction of to 45. But I spoke to MSD, and as far as we know in South Africa, there's only one restriction for Gardasil 9, and that you have to be the age of 9 plus. So the one other place where I will come to as well, which I found quite interesting, is the use of HPV vaccination in healthcare workers, which I honestly, I don't know why, but from the beginning of the year, I only started thinking about it now. There is theoretical risk that when we do LETSs, the HPV can be vaporized and we can inhale it, and it can settle on tonsils and the back of the tongue. And just as an aside, an interest sake, tonsillar tissue is very similar to the transitional epithelium of the cervix. I didn't know that. So HPV vaccination is actually advised for someone doing LETSs. So essentially all gynaes should be having the HPV vaccine, male or female. World Health Organization, at the moment now, they're only focusing on females. Older females can be vaccinated, but only if it is affordable. So there. This is just highlighting the immunization schedule. So going back to what I said, remember I said that if someone is vaccinated at a younger age, below the age of 15, the antibody response that they mount is much superior than someone being vaccinated above the age of 15. Okay, and also their response is also higher if they are vaccinated while they're HPV naive. So as I said, get vaccinated 11 to 12. If they become sexually active at 13, 14, they still have a very good immune response and they're vaccinated. So there's the response is so good that you can actually do a 2-dose vaccination program below the age of 15, but above the age of 15, everyone will require 3 doses of the vaccine, okay? Just as an aside, anyone who's HIV positive requires a 3-dose schedule, even if they're less than the age of 15, just because there have been documented studies that with HIV, the antibody response is slightly lower. The dosing schedule, so for kids is 0 months and then initially, and then 6 months later. And for adults, it's initially 2 months later, and then 6 months, I am going to come to some common things about missed doses, which we get asked a lot. So I thought, what happens in South Africa? Because to be honest, I had no idea. From our side in private, we can send someone to go and get the vaccine, but I was like, what is available in private healthcare in state healthcare for people with HPV? So I had to actually chat to Prof. Rizani Muloiwa, who's from Red Cross, and he is a vaccinologist, and his team were actually really helpful and really passionate. They referred me also to a website, which I've highlighted there, if you want to go and get some more information. And they are vaccinating girls in grade 5, as long as they're above the age of 9, during campaigns, but the parents and caregivers have to give written consent. So if there's no consent, they cannot vaccinate. If they miss that vaccination, then they must go to private. I asked, are they possibly going to think of vaccinating boys? There's no plans yet or anytime soon to vaccinate boys. And I said, what happens in a private school? Do these campaigns go and visit private schools? And the answer is no, they don't. And just going over, the bivalent vaccine is 109 Rand, and that's what they are using to vaccinate. This on the right was just something I found. It was the beginning of the year. I'm sure they've had more campaigns since then, but this is on the Western Cape Department of Health Facebook page. So they are quite active, and if you guys want to go and follow it, they do quite a few adverts for their campaign. So it is definitely happening. We just need to encourage people to actually have it done. I asked MSD, because I think being in the private sector, we need to talk about costs. So one of the big things I noticed in the private sector is you can get 1,000 vitality points for getting the HPV vaccine, which is great. Cost of Gardasil 9 and Gardasil 4. So we can see there, Gardasil 4, 945 Rand and 62 cents, whereas Gardasil 9, 2,020 Rand and 64 cents. I don't know if you guys have had any complaints about the prices. I know a lot of my patients have kind of complained, and a lot of them don't fulfill their full vaccination schedule. I spoke to Discovery about covering the vaccination, and for Discovery, Gardasil and Gardasil 9 can be claimed from your savings account, but only if there are funds, which some patients don't understand. Other medical schemes, Gardasil and Gardasil 9 can be claimed from the risk benefit or the day-to-day benefit. So like my advice is to obviously chat to your provider before getting the vaccine. So there's some special prescribing circumstances, and these are the kind of phone calls I get quite a lot from GPs and also some pediatricians. So pregnancy and breastfeeding, so it's not recommended. Lactation, you can vaccinate during lactation. So this is a very common question that people say that pre-existing HPV disease, you cannot get the vaccine. And that's not true. It is still recommended because you can get protection against HPV types that are not already acquired. Healthcare workers, as I said, ASCP has advised for healthcare workers or healthcare workers working with HPV and doing letters should definitely have the vaccine. The immunocompromised, I've already kind of said that they need a 3-dose schedule no matter what their age is. Their antibodies are less robust and they have a shorter lived immune response. Missed doses. So this is one of the most commonest questions I get, because a large proportion of people don't complete their vaccine schedule, either cost-wise or they kind of just forgot, and they mostly forget about the 6 months vaccine. So what can you do? You don't have to restart the vaccine schedule. You can just give the dose. So if they had their first dose, second dose, and they waited a year for the next dose, they can just get that 1 dose and they can consider themselves vaccinated. Then this is their question. What if I already had a bivalent or quadrivalent? What if I already had the bivalent or quadrivalent vaccine? What should I do? Should I go and get Gardasil 9? And the guidelines I've saw and found there's marginal individual benefit, okay? But they must consider that there's increased cover, particularly between bivalent and quadrivalent with 6 and 11. Next thing is there's no need for pre or post-vaccination serology testing done, like some other vaccines. 2 doses or 3 doses. So there is clinical efficacy studies that evaluated 3-dose schedules. Observational studies showed that fewer than 3 doses is still associated with reductions in cervical neoplasia, but 3 doses above the age of 15 is still recommended to get a good immune response. I think it is always important to just chat about screening, because HPV vaccine is changing things quite dramatically. And how does this affect screening? So HPV vaccine, we have to think it's not effective in clearing HPV. It doesn't clear genital warts. It doesn't clear sin lesions. It doesn't provide 100% protection for all oncogenic types of HPV. So an optimal approach to screening post-vaccination is not established. Therefore, you continue your normal screening program wherever you are. If you're in the private sector and you're doing co-testing, you continue that. Or if you are in the state sector, you continue with whatever screening program is available to you. So nothing alters. So I think it's always important to look into the future and think what is available. HPV vaccine is amazing, and hopefully we can eliminate cervical cancer in the next 100 years. But I think we need to go beyond prevention. And there are a whole lot of these new therapies that are available. And you need to ask yourselves, can you use the vaccine as adjuvant treatment for someone with sin lesions, which we'll come to now? Are there any therapeutic vaccines that can actually target HPV, and can they target sin lesions? One thing that has been proven is improved pregnancy outcomes. When I first read this, I was like, how on earth can HPV change pregnancy outcomes? And the underlying issue was that HPV vaccine decreases sin lesions, which would decrease letters and decrease cone biopsies, and therefore decrease chances of things like preterm labor and second trimester miscarriages. So looking at HPV as an adjuvant therapy. So there was an analysis of a large randomized phase 3 trial, and it showed that there was significant reduction in the relapse rates of high-grade cervical disease of 64.9% amongst post-treatment women, meaning they had a LETS or treatment for their sin lesion, who previously had received the vaccine. So it was a Chinese study. It looked at the bivalent vaccine, and they asked themselves, was this due to a therapeutic effect? So was the vaccine actually destroying abnormal cells? Was it actually destroying HPV? Number 2, was it a primary prophylactic effect on the newly developed lesions caused by new HPV infections after treatment? Or was there kind of a secondary prophylactic effect of the vaccination in reducing the ability of the residual virus to infect new cells? So they did a study, and so if you look at the bottom right, it's quite a nice little graph to show follow-up time after an intervention. So that either being a LETS or a cone biopsy. And the one group that had previously received the vaccine, and the bivalent vaccine, is in blue. And you can see that their rate of recurrence was much less compared to the placebo, or the group that didn't receive, which is in the green. So what they found ultimately is that there's no significant evidence that a bivalent vaccine could lead to faster viral clearance or have any effect on persistent HPV infection. However, they concluded that there may be a benefit from a primary prophylactic effect. So this is called they did the Patricia study, and it also looked at similarly looked at HPV 16 and 18. And they looked at previous vaccination with a quadrivalent HPV vaccine amongst women who had surgical treatment for HPV disease, significantly reduced the incidence of subsequent HPV-related disease, and all coming to the same conclusion that it didn't actually treat, but most likely was due to this primary prophylactic effect, so the patient would not be exposed to more HPVs. So therapeutic vaccines, which is kind of a new era, and there are 3, or maybe one now that's also being not available, but under investigation. So VGX-3100, MAV-E2, and TG-4001. So what these are, so MAV-E2 and VGX-31, they are nucleic acid vaccines. They're both still in phase 3 clinical trials. They're aimed at patients with HPV-related HSIL. They've been well tolerated, but they're unfortunately still unlicensed. Their clinical efficacy It did actually show modest regression in HSIL, which is great. And it did show clearance of persistent HPV. So I think there can be some progress there. What they do is, unlike a prophylactic HPV vaccine that induces an HPV-specific antibodies to neutralize invading viruses, the therapeutic DNAs induce cytotoxic T lymphocytes to eliminate HPV-infected or transformed cells. And they basically create a cell-mediated immune response. What are the problems with these vaccines? So its problem is getting the vaccines into the correct cells for efficient expression and presentation of the HPV antigen. So how do you get this antigen into the cervix? How do you get adequate coverage for the oncogenic types? So you want more than just 16 and 18, you want 31, 18, 45, all the other ones. And how, as I said, how do you direct the immune protection to the epithelial niches? So for example, the cervix and the anogenital mucosa. So it's difficult to establish time windows, difficult to establish vaccine regimens, and then how do you validate this therapeutic efficacy? So all of them are currently under a lot of investigation, and this is just a timeline that I found of all the therapeutic vaccines. And of note, I think just have a look at the start is in 2000, which is preclinical trials, and we are now in, we're now in 2021, around about there, and some of them are only in phase 3. So I mean, a good like 15, 20 years are going into these. So it's a kind of a very slow process. Some other therapeutic vaccines that we can see. So GX188E is still in phase 1, and PB111 or 2 is still in phase 1. But they are both quite promising for SIN regression, and they have good tolerance and for clearance of HPV. What I found a bit interesting is how do these actually work? And I heard about, for the first time a while ago, this thing called electroporation. So the therapeutic synthetic DNA vaccines, which target 16 and 18 E6 and E7 proteins, they need to be delivered by electroporation. It's the use of a high voltage electric shock to induce DNA into the cells. So I asked about this. Patients are injected, and then this machine, which is in the bottom left-hand corner, is applied to the injection site, and that hopefully puts the virus into those cells. So I think it's always important to look at what's in the future and what may come. So in summary, I think we just need to realize that the HPV vaccine is highly infecting and preventing HPV-related disease. We need to encourage vaccinations to achieve elimination. I think the older population is a very important group that we see a lot in private, and we need to take them seriously, and we need to give them the possible benefits. Vaccine as a treatment, we chatted, I think it is possible, but it is definitely something for the future.
Thank you. Thanks so much, Jason. That was really very informative, and I think it's going to certainly change clinical practice for a lot of us. And I mean, I think highlighting the value of these vaccines in the older patients that most of us didn't really think would benefit, or that it was really an option. So I mean, even I never thought of vaccinating someone older than 45. But I mean, are you offering it to your patients, Pete?
Yeah, Steve, as you say, these are new horizons, and I think it's exciting that we can use them in this way. I certainly do.
Yeah, no, very exciting.
Having more, I mean, people in their 40s are having newer relationships, people are ending relationships and starting new relationships, and can get definitely being exposed to HPV. So I think it is important.
What's the oldest patient you've vaccinated, Jason?
She is 44 years old.
All right.
Yes.
There's actually a question here saying Gardasil 9 covers many more HPV types. What is the reason for delaying it till age 45 in women?
Oh, no, so there's no reason to delay. You can now use Gardasil 9. Just meaning Gardasil 4, the age restriction was up to the age of 45. So I think they looked at clinical benefit, and there wasn't much benefit above 45, so they didn't use it. Gardasil 9, according to MSD, has got no cutoff. So their age restriction is just 9 years older. So you can give it to anyone.
So you can basically give it to anyone. It's just don't give it to anyone younger than the age of 9.
Yes, that's it. Yeah.
There's another question here from your friend again, Habib.
Oh, Habib, yeah,
yeah.
anonymous from Kenya, who we know
Yeah.
we've Habib, yeah.
Yeah. Is it obligatory to perform HPV screening before offering an HPV vaccine?
So you don't, it's not, no, you don't have to. Because remember, you can give it to anyone, and you're not, even if you come back as a 16 positive, remember, you want to still have cover for the other one. So you don't necessarily have to. It just depends what screening program you are using. So for example, if you're using a code test with extended genotyping, then obviously you will have those results, but not necessarily, you don't have to test. You can give it without testing for HPV previously, because it won't change your management. You'll still give it.
Is the data quite convincing for the risk of HPV and the tonsils and in the throat?
It's not that for with regards to people doing letters, it's not convincing. It's not convincing data. It's more theoretical risk.
Right.
And with tonsillar cancer that we looked at, obviously from our side, we get exposed to it, but also the patient side, tonsillar and base of tongue cancers present in the 5th and 6th decade, and they are HPV related. So I think that's something we should also talk to patients about. We focus on just this cervical cancer, vulva, vagina, which is important, but I think it's also, and warts, we should also just tell them about these upper area digestive cancers that are important as well.
Yeah, Dr. Basson, maybe I've missed it, but should we give a booster doses after 10 years?
No booster doses is advised.
So
the studies all say that there's cover for at least 10 years, most likely longer until they have more research, but for now, no booster dose is advised.
Okay, and then Harry Thompson brought up a similar question about missing, what if the patient missed their second dose at 2 months, must they start again? And you said you can just continue with where you left off and no sets up doses. Okay.
Yeah, continue where you left off. Yeah.
Your friend again has asked, vaccine is prophylactic, a 45 years not exposed to HPV.
So that's great. I mean, that would be ideal, because that means it's difficult to say if someone's not exposed to the age of 45. I mean, if someone is absolutely never had any sexual contact with anyone or any form of sexual contact and they're HPV naive, then obviously their response would be great. But then obviously your response is going to be better when you're at the age of 15. So if they're HPV naive, all the better.
Okay. And then 2 more questions. The role of the Department of Health in HPV vaccination in schools. Is it a free program running through?
Free, completely free. I think one of the biggest barriers is patient consent that they need to sign for.
Except that it's on girls only. It's not for boys.
It's not on boys, and there's no plans for boys yet.
Steve, are you your boys? My boys.
Did you?
Yeah.
It's still a bit small. I'm sure there'll be something else by then.
So I told someone today about vaccinating her daughter. Her daughter is 9, and she said her daughter's not going to be ever having sex. So
I've heard that before from yeah. We won't go there.
So it's a touchy subject, but as I said, you need to get them vaccinated before they have any sexual contact.
And then one last question from Esther Olusola. If the nonavalent vaccine is given after the bivalent or quadrivalent, are the 3 doses still required?
So if a nonavalent is given after the bivalent, it depends where you were on the bivalent vaccine. So just to see how many doses of the bivalent you had. So I suppose if you had 1 dose of the bivalent vaccine, then you can just move across straight away to the non-valent vaccine. So Cervarix, and then your 2 months time you can get the 9-valent, and then the 6 months later could be 9-valent as well. There's no reason to restart.
Okay, here's Anonymous again. He really is active today. Pap smear, NILM. What does that mean?
No, not negative for malignancy.
Okay. HPV 45 detected. How would you approach management?
I would do, and so it's NILM and HPV 45. I would do a colposcopy.
Okay, that's that. Leon Nell says, this keeps jumping. So why HPV is the main cause for cervix cancer? What does that mean?
Nice. So HPV causes 99 point something percent of cervical cancers. Remember, there is a proportion of cervical cancers that are not caused by HPV. As I said, Judy Whittaker did a talk about is primary HPV screening the death of the pap smear? And I think the conclusion was no, the pap smear is not dead yet. You will, just doing primary HPV screening, you will miss some cervical cancers. So not all cervical cancers are caused by HPV.
And then what? Can one vaccinate after sexual debut? The answer must be yes. We've said that.
Yeah,
Because
that is one of the big take homes, eh? I mean,
Yeah.
it's irrelevant and appropriate in everyone.
Just before Steve thanks you, Jason, we have Lorraine Gavender from Cancer. She's going to be saying a few words after your presentation and how Cancer Association of South Africa can support doctors and patients with a cancer diagnosis. And I'd just like to thank Lancet Laboratories for the sponsorship of this afternoon's program. And Steve, over to you. And remember, next week is the 18 to 22 week scan by Dr. Natalie Odell. So we're approaching the end of our webinar. We're running out of bandwidth. We have a few minutes left. And Lorraine Govender is going to be saying something after you said a few words of thanks to Jason.
Yeah, well, yeah, from our side, Jason, thanks. It was an excellent talk. I certainly feel that you highlighted a lot of the very important issues. You brought us all up to date, and I think you've changed practice. I mean, I'm certainly going to discuss it with some of my patients, especially, I mean, it can be effective at any age, really.
Absolutely.
I mean, yeah,
Doesn't seem to be much reason not to.
Yeah, I mean, we will be vaccinating 60 and 70-year-olds soon. I mean, they're very active in old age homes, and why not?
Yeah.
I mean,
I'll
why
think
not
about
vaccinate?
It's
Yeah.
expensive. I mean, it's not without its costs,
Yeah.
but it certainly is food for thought.
Yeah. Thanks.
Thank you so much, Jason.
Thanks for having me.
It was an excellent presentation, huge number of questions, and God willing, we have you again in the not too distant.
Definitely, anytime.
Thank you very much indeed.
Thank you.
Pleasure. Thanks
And
for
now,
having me.
thanks very much for Karen indeed as well. And are you going to then give us Lorraine Govender from Cancer on how they can support us and our patients with cancer diagnosis?
Hi there. Good evening, everyone. I think I'm just going to show one slide, but I think I have a problem sharing it. Okay, it doesn't matter.
Lorraine?
Hi.
Do you need some help sharing?
Yeah, something's gone off on my side, but it's fine. I can just talk us through it. So, Dr. Ben, I want to really say thank you as well for that very, very interesting presentation. And one of the things that you spoke about was the challenges in terms of the HPV vaccination, where people are not going in for the vaccine. And we see that all the time at the Cancer Association. So it's a lack of information, and people, I think, don't want to really tie the HPV virus to cervical cancer. They don't see that link. And I think we need to do more to talk about it and encourage people to go for that. So that's one of the campaigns that we work on in cancer. So if people want more information, they can always look at the cancer's website, which is www.cancer.org.za. Or call our help desk 0800 22 6622 to find out more information. So we also are working very closely with the Department of Health, where we've prepared letters and we've put out information on our website on the myths with regards to the HPV vaccine, trying to get the anti-vacciners to actually stop and change their attitude and minds. But I think the whole COVID situation also has put people are very reluctant to go in for that. So cancer also conducts pap smear screening at our various cancer care centers. So the public that are interested in that can also access that. So as you know, having a cancer diagnosis is also quite traumatic. So anyone that is interested, we also have a really good counseling line. It's a telecounseling line. and it's available in most languages, over 5 different languages. So those that do have a cancer diagnosis and you're looking for support, please look at our website and you can book an appointment for a free telecounseling session with one of our social workers. So Karen, I hope that's been okay and I've made it on time in
You
terms of.
have. Thank you
Okay.
so much.
All
And if
right.
anyone needs
Can I,
that
can I just
information,
ask
repeat
Lorraine a
it.
question? Lorraine, you said making more information available to non-vaxxers is useful. I must say that if you made a truckload of vaccination
It's hard.
data, and if you made a
Mm.
second dumpster available, they have an idea in their head which is anti-vaccination, and it's not based on amount of knowledge or the amount of research. It's based on an idea in their heads. And I must say
Yeah.
that I feel that it's going to be very difficult, if at all possible, ever, to change an anti-vax into vaccine, because it's a religious crusade they have that vaccination is bad, and any amount of information you can give them will not change this time. That's the way I feel.
Yeah. And you know, the scenario in our country is a little bit different, where crime is so high. As much as you say, okay, I know who my partner is, and you know, all of those sort of things, but the crime and rape stats are quite high in our country. So, you know, as much as we can say we're going to avoid, but these are the real situations. So having that HPV vaccine is important. But also on the other hand, Stephen and Jeffrey, is that people don't know, they don't see the link. And this is what we find. When you talk about the HPV vaccine, they don't know about it. It's a secret. That's the problem.
We come in
Okay.
maybe, but really speaking to people about it. But thanks to everybody. I think it's a wonderful session.
Thanks,
A
Jason.
lot of food for thought, and a lot of action may be required as well from everyone's side.
And
so
now,
thanks
having
so
had,
much.
having had thoughtful food, now it's food for thought. Now it's time for thinking of food, yeah. And a great big thank you then once again to Lorraine, to Lancet, and to Jason Bennett, and of course to Corin, and once again the Pelvic Floor Foundation for sponsoring.
Okay,
Safe home, good night. Steve, thanks for the use of your mini bar. And next week, don't forget a wonderful talk on the 20-week scan. And we look forward to having you all back. Same time, same place, and safer.
Thank you very much. Bye-bye.
Right.
Bye.